So this is the second ERAS session. I'm Dan Engelman. I'm a cardiac surgeon from Springfield, Massachusetts, and president of the ERAS Cardiac Society. And this session is specifically tailored to look at how ERAS components and ERAS orders and order sets and protocols can be used to reduce the complications which result in your star ratings, which is very important to us in North America at least, and it's important to everybody in the world. I would invite after each lecture the speaker to come sit up here with me and join me. We'll then have some moderated questions. So kicking this right off, we're going to start off with our first talk by Dr. Shubha Chatterjee from Houston. He's going to discuss the dreaded complication of CVAs and how to avoid embolic stroke. Thank you.
I'd like to thank the organization for the privilege of speaking today. We'll talk about cerebrovascular accident and how to avoid embolic stroke. These are my disclosures. Stroke is the #1 fear that patients have heading into coronary bypass surgery. 3,000 patients surveyed. What were they most concerned about? Going into operation, #1 was freedom from stroke. #2 was staying alive for as long as possible. So this is at front and center of our patients' interest. The stroke risk after CABG is certainly lower than after major aortic surgery. It's a little bit higher than it is after isolated valve surgery. And you can see with concomitant valve CABG that the risks go up. The most common risk factors are pretty well known: previous stroke, atrial fibrillation, carotid artery disease, and so we know these. How about the differences between the types of stroke that occur after CABG? So Mario Godino reviewed in a systematic review 33 studies, 175,000 patients, really characterizing the difference between early versus delayed stroke. Early stroke is intraoperative. It's because of aortic manipulation. About 3/4 of these are due to atheroembolism, about 1/4 from hyperperfusion. Postoperative stroke is really related to atrial fibrillation and cerebrovascular disease. You can see the incidence is roughly about 1% for either of them. The implications, however, are significant. Intraoperative stroke is associated with a nearly 30% mortality and increased late mortality. Delayed stroke may be a little bit less, about a 20% intraoperative mortality, but 10% late mortality. And you can see clearly much worse than those patients who do not suffer a stroke. So how do you avoid intraoperative stroke? Mike Mack in an editorial really characterized the major features here: epiaortic ultrasound, avoiding aortic manipulation, clampless proximal, single cross bypass. And there are other factors that can be utilized, you can see here, for techniques to avoid hyperperfusion during stroke and trying to identify those patients who are at highest risk of atheroembolic phenomena. I'm going to focus less on this. I'm going to focus more on trying to reduce the incidence of delayed stroke. And we'll specifically look really at what the data exists for anticoagulation after atrial fibrillation, left atrial appendage elimination, and preventing post-op AFib. So what is really the risk associated with post-op AFib? There's a large systematic review and meta-analysis, 55 studies, over 500,000 patients. And what I'd really like to emphasize, because I think this clouds a lot of our messages that we give to patients, is understanding the difference between relative risk and absolute risk. Relative risk sounds impressive, but it's really the absolute risk and the number needed to treat or to harm that really carries the most significant implications. So when you look at short-term stroke risk, this is early stroke, after the relative risk reductions that you see increases associated with stroke after AFib are pretty substantial. Somewhere between 80 to 120% of patients are increased risk. But when you really look at it in terms of an absolute risk difference, it's probably a little bit smaller than we actually recognize. After CABG, the number needed to harm is almost 70 patients who develop AFib will have a unique stroke. So this is important in terms of what sort of treatments we can do and how important it is to try to prevent things. The long-term risk is even more modest. You can see here the number needed to harm is certainly smaller. So what does this mean in terms of how we approach things? Now, this is a characteristic, this is anticoagulation, this is the classic study that is why we anticoagulate patients after AFib. Systematic review, this is a systematic review. You can see here, we all know this number. Anticoagulation after AFib cuts the stroke risk in roughly 2/3. But what we don't always appreciate is the absolute risk reduction. This is what it really means. You need to anticoagulate 37 patients with AFib before you prevent one stroke. Those patients who have had a stroke in the past, it's even more significant. It's actually up to 12. So this offers a framework for how to understand this. So we looked at really what was really the significance about anticoagulation after atrial fibrillation. How do the guidelines help inform us? So the American guidelines and the anesthesia guidelines issue a 2A recommendation for anticoagulation after atrial fibrillation. The European guidelines were a 2A recommendation, but their 2020 revision actually scaled it back, stating that the evidence on which anticoagulation in patients with post-op AFib is actually not very robust. The Canadian guidelines are even a little bit more circumspect, saying we should wait 72 hours and really make it on a real cost-benefit analysis. So how effective is anticoagulation after atrial fibrillation? This is the Swedish registry. In Sweden, they can take Medicare, they can take their healthcare data, integrated with their cost data, their tax implications, and put it together. So you see here, 1/3 of the patients who after CABG developed AFib, 1/4 of them were subsequently anticoagulated. When you actually look from a Kaplan-Meier standpoint and you risk adjust it, there is a small increase in mortality and stroke and certainly recurrent AFib in those patients who develop AFib. But when you look at the patients who were actually anticoagulated, they weren't that different from those who were not. The standard guideline is you should anticoagulate anyone over a CHA2DS2-VASc over 2. You can see almost all of these patients fit that category. More than half of the patients were actually CHA2DS2-VASc greater than 4. So how did the patients who got anticoagulated do compared to those who did not? You can see here that there was no difference. No difference in mortality, no difference in stroke, no difference in thromboembolic events. It was as if anticoagulation showed no benefit. Do the systematic reviews and meta-analyses help us? Not really. These are the two largest ones that are there. The one on the left, no difference in thromboembolism, maybe a non-significant trend towards a survival difference. The one on the right, maybe a little bit different, but not really much. We don't get a lot of guidance there. Maybe the CHA2DS2-VASc score can help us. This is the Sweetheart registry. What you see here is that it wasn't until you saw a CHA2DS2-VASc of greater than 4 did you start to see a little bit of a benefit in anticoagulation, certainly more than what we'd expect. So what are we doing now in the US and North America for our oral anticoagulation? In published series, the range of anticoagulation ranges between 25 to 40%. STS database, 166,000 patients after CABG who developed AFib, 1/4 of those patients were discharged on oral anticoagulation. Interestingly, only 1/4 were actually discharged on anticoagulation, but the vast majority were discharged on amiodarone. No real difference in CHA2DS2-VASc score between those who were or were not anticoagulated. A slightly increased trend towards those who were anticoagulated having higher CHA2DS2-VASc score, but you'll see even those patients who had a CHA2DS2-VASc score greater than 5, that's a greater than 12% annual stroke risk, less than 1/3 of them were actually anticoagulated. But at the end of the day, there was no difference in survival between those people who were anticoagulated and not anticoagulated, no difference in stroke, and a 4-fold higher increase in bleeding. It's as if post-op AFib is different. So you're probably like this too, as am I. But I think there's probably some data to suggest we're probably too aggressive in anticoagulating low-risk patients and maybe not aggressive enough in anticoagulating high-risk patients. How about DOACs? Do DOACs show a difference? At the end of the day, not really. So no matter what your STI, no matter what here's a registry study looking at DOACs versus warfarin, and you can see here no difference in, slightly higher increase in bleeding complications, but no difference in terms of stroke data between DOACs versus warfarin. Systematic review of DOACs versus warfarin. No difference really in bleeding, very little difference in neurologic events. So we don't really have a good answer with DOACs either. So maybe the PACES trial that's upcoming will help us. So what else can we do to reduce AFib? So what's the role of the surgeon in this? Surgical ablation, we heard a lot about this. We should do it more often. We're not doing it, but it's a two-way indication to reduce stroke, and it's certainly underutilized. So this is what we're trying to avoid. So we're trying to recognize that the left atrial appendage clearly has a significant role within stroke management. This is the WS13 trial. At 5 years, 2.7% absolute risk reduction in preventing a stroke. That's a number needed to treat of 45. It's now a class 1A indication. We should do it. Interestingly, the people who most benefited were actually the healthier patients. But at the same time, we actually end up doing less to the appendage the higher the surgical risk goes. How about prophylactic left atrial closure? We should not be doing this at this time. The evidence does not support it. This is true in a large analysis from the Mayo Clinic. This is true from the Laos data. This is true from Dr. Gerdish and the Atlas trial. We don't have this evidence yet to suggest preoperative prophylactic appendage closure is helpful. So how do we reduce it? So here, it's very difficult to prevent post-op AFib. Posterior pericardiotomy, very simple technique. Small incision. Mario Godino and their Palace trial, number needed to treat of 7 to prevent AFib. Systematic review of 10 studies showed the exact same thing. For every 7 patients you do a posterior pericardiotomy to, you prevent 1 case of atrial fibrillation. So this is what we're trying to go to, and this is downloadable based on the QR code that you can see below you. This is what we developed as the ERAS Cardiac Society to try to reduce AFib. Preoperatively, beta blockers and amiodarone. You can see the intraoperative, and you can see the postoperative measures. And I direct your attention to this slide. This is the number needed to treat to prevent 1 case of AFib. If you use pre-op beta blockers or amiodarone, for every 7 patients you treat, you prevent 1 case of AFib. If you look throughout this slide, there are very few other interventions that can do this. So the key is what we can do to prevent AFib, which is going to be our best marker to prevent the risk of stroke. So in summary, about half the strokes that we get are delayed, they're postoperative. We need a comprehensive and I would say a deliberate approach to reduce the incidence of AFib, both by the surgeon, by the ICU team, preoperatively and postoperatively, and we should be thoughtful in our approach to anticoagulation, whether it's the CHA2DS2-VASc score or AF duration, but this is ultimately going to be the most helpful that we can be for our patients. Thank you.
Thank you so much, Dr. Chatterjee, for such a fantastic speech on how to prevent postoperative stroke, especially how to prevent postoperative AFib. I'm Dr. Hu Zhan from Fuwai Hospital, Beijing, China. It's my privilege to join this session, as ERAS is what we are trying to initiate to improve revision chairs. And now let's move on to this next speaker. It's Dr. Makalina Yeman from Department of Thoracic Surgery and Critical Care, Mount Sinai Morningside Medical Center.
Good morning. Thank you. It's a pleasure. Dr. Busquez, my boss. So I am actually the new face of cardiac ICU here. I hate public speaking, by the way. But this, ICUs are changing in cardiac surgery. I think a bulk of you yesterday presented, and a lot of the anesthesiologists are covering ICUs. But in most centers, it's people like me that cover the ICU. I come from a medicine background. I'm an ID doctor. I did critical care training. A lot of our intensivists in our institution actually come from many different medicine backgrounds. We have nephrologists, we have internal medicine doctors, geriatricians that have done critical care, and you're handing your patients to us. So you have to be aware of where you work, as well as who you're handing your patients to when you're talking about postoperative care. You have to have a team that's comfortable taking care of patients after you do surgery, because medicine is changing and it's a collaborative team now. So I'm going to talk about prolonged intubation and the outcomes that we see in our ICU. We all know prolonged intubation in cardiac surgery is defined as intubation longer than 24 hours, but that's really kind of cheating because a lot of our patients that require intubation for longer than 24 hours have other issues that we're dealing with in the ICU. It's the SES metric, which is publicly reported and tracked. We know it increases morbidity and mortality, but we talk about cost a lot, and working in America, cost really is not something we should mention because we have the costliest healthcare system. And if we want to cut cost, this is not where we should cut it, it's elsewhere. But there's a lot of strategies that have been introduced in terms of early extubation on how can you get the ET tube out in your patients earlier and how does it impact their outcome. We talked about early extubation in the operating room yesterday. Again, when you extubate in the OR, you're handing them to me, so make sure that I feel comfortable taking care of these patients in the ICU. And I've worked at an institution where they did OR extubation on 50% of the patients. And I will tell you, for the ICU team, it's a lot of work, right? You hand them over, but the nursing team has to be comfortable. The intensivist has to be comfortable taking care of these patients. Not everybody emerges out of anesthesia in a nice way. There's a lot of agitation. And you don't want to extubate somebody and put them on BiPAP. I think switching a safe airway to an unsafe airway is always a bit of an issue that we need to discuss. There's a strategy of ultra-fast track extubation where you aim to extubate patients within 3 to 4 hours. I think that's feasible. And the SES advocates for extubating patients within 6 hours, which is really what we all are trying to accomplish. And this is going to be, if not already, a quality metric that's going to be tracked soon. The benefit of all of this is really the reduction in ventilator time. That's really the one thing that we can all agree on. Everything else is kind of iffy, depends on the data that you're presenting. In terms of ICU length of stay, some centers have shown that you reduce your ICU length of stay. Maybe, maybe not. Utilization, source, and cost, again, are other things that we really should focus on because there's other ways to reduce cost and utilization, and I don't think this is the place where we can focus on that. In terms of the ultimate benefit to the patient, I don't think we've shown any evidence that says extubating them in the OR or within the first couple of hours actually improves their outcome overall in terms of survival, morbidity, mortality. So things to consider when you are adapting an early extubation strategy is really know your patient population. In our CABG program, everybody's stented before they're referred for a CABG. So we always get the low EF, elderly, morbidly obese, really tough patients when they're coming to Dr. Puskis for surgery. If you're getting an elective population, maybe your success rate may be better, but knowing your patient population is key. And COVID has really impacted how we operate in the ICU, at least in the New York area. There's a constant turnover of staffing. Nurses are essentially in the CT ICU for 6 months, and then they're going to do their CRNA. So we're a revolving door of nursing as well as other ancillary services. So having a team that's going to be able to quickly train and adopt your strategies is key. A lot of the data that we have in terms of early extubation is from single-center studies. They're usually retrospective or observational. And then there's no randomization to tell us that extubating within a certain time actually improves outcomes. So we really do need better data. I've already mentioned the cost part, so I'm not going to say that again. But the bias that a lot of the presenters, especially yesterday afternoon, didn't really mention is all the programs that have a successful early extubation strategy are the ones that have fully adopted ERAS, right, from the beginning, from the preoperative part all the way to the ICU, OR, and then even after discharge. So if you really want to have a successful early extubation program, you really should adopt ERAS in its entirety. Things like prehabilitation, smoking cessation, improving patients' nutritional status, simple thing as giving your patients an incentive spirometer in the preoperative visit so they know how to do that post-extubation actually goes a long way. So adapting a strategy of optimizing patients before you operate on them is really the key. The data from all of the OR extubation literature that we have available at our hands, things have to be perfectly aligned to extubate your patients in the operating room. And there's a certain percentage of patients that probably fall into this category. I would probably say 5 to 10%. You really need to have a perfect intraoperative course. The technique, obviously minimal transfusions, minimal complications in terms of bleeding. Hemodynamics need to be good. You need to get to normothermia at the end of the case. You need good fluid balancing. If you're on pump, you need the help of your perfusionist to get your fluid status optimized. In terms of, we heard about chest closure techniques yesterday, so things like chest closure as well as what type of chest tube you use may help minimize pain later, so all those things need to be considered. The anesthesia approach, we've heard about having a balanced anesthesia, low narcotic, low benzo, using regional blocks as much as possible. And then we talk about costs, so really reversing paralytics. If you use Sugamidex for all of your patients, how much is your pharmacy gonna love you? So you really need to commit to cost reduction is not always the case. Sometimes you do have to spend money in order to succeed in that. And your patients need to wake up at the end of the case and be able to take good tidal volumes and have respiratory effort. So this may not apply to the majority of our patients, at least in our institution. Some of the predictors that have been mentioned are age, BMI, minimally invasive and off-pump CABGs, and a low narcotic, low benzo anesthesia strategy, and the nutritional status of the patient and the strength of the patient also matters. So you need to have all these things aligned in order to extubate your patient in the OR. But again, these are things that we should ideally do in every patient, whether we plan to extubate them in the OR or not, because I think it will improve our success rate overall. For early extubation, as defined by SDS within 6 hours, I think if you look at the SDS database, most CABG programs are achieving this. There's a huge buy-in, so we don't really need to spend a lot of time. 60% of patients are being extubated. We just need to increase that number a little bit more, but there's a lot of confounding factors that may impact that. So the low moderate risk, I don't know how many programs get low moderate risk patients. We all get maybe moderate, a little bit of high-risk patients nowadays, at least in the New York area. So low moderate risk patients should really be considered for early extubation, and even sometimes, if you are brave, OR extubation, or it fits routine for you, OR extubation as well. Anesthesia selection, I'm a lover of Precedex. I think everybody should be on Precedex. I said that yesterday, but transitioning to medications like Precedex, sometimes ketamine, or even propofol at the end of the case, so patients emerge quicker when they arrive to the ICU, is ideal. Using chest wall blocks or regional blocks whenever possible. This takes a multidisciplinary approach. You have to get a buy-in from not only your OR team, but from your ICU team, and everybody has to be dedicated to accomplish this. There's no protocol that's available for every institution. I think all of us have adopted our own fast-track protocol, but adding a time component to it may help you accomplish this sooner. But then we ask, well, most of our patients may not fall into, or some of our patients may not fall into that 6-hour window. So what happens if you extubate your patients after 6 hours? Do we see poor outcome or increased morbidity and mortality? And if you look at the literature, the outcome is the same as long as patients are extubated within 12 hours. So the question is that 6-hour mark a magical number, or should we just try to extubate patients earlier? In my opinion, I think the earlier we do it, however it works for you, probably the better. The longer you wait, more than 12 hours or so, complications such as delirium, obviously barotrauma, and ventilator-associated pneumonia tend to increase. This side is really our process here at Mount Sinai Morningside. We've adopted it into our EPIC protocol. What it lacks is the time perspective. This is a recent data that was presented from University of Washington. They're a little bit biased as well. If you really look into the data, they probably have a good process at hand, because even before introducing this 3-hour fast-track extubation, they've been extubating their patients within almost 4 hours 5-hour period. So they fine-tuned it a little bit to expedite that process to 3 hours. But what allowed them to do that was adding the time component. So when you generate your process, maybe add the time component so you give guidance to your team. Most protocols, at least in the institutions that I've worked in, are nurse-driven or respiratory-driven. So you kind of hand this process to your nurses and your respiratory therapists, so give them guidance of how to kind of proceed and just don't make it blind, so they can actually have a goal to reach. So in terms of outcomes, so is there any benefit in extubating patients in the OR? And the data actually says no. In terms of your length of stay, hospital length of stay, ICU length of stay, it doesn't really change. What about extubating patients within 6 hours? The data is the same. It really doesn't change your overall length of stay in the hospital. I think until 12 hours, things don't really change. And to be honest, ICU length of stay is not really dependent on the ventilator time, but other things, right? Maybe the patient's condition, or you're optimizing their respiratory status, or you don't have beds available, but other confounding factors actually impact your ICU length of stay. I think the longer you push the intubation time past the 12 hours, you do tend to have problems like delirium and infection and other common ICU complications. But in this day and age, at least in most CABG programs, when we start seeing the longer intubation time, it's usually not a ventilator issue, it's some other issue that we're trying to optimize for our patients. So we need to kind of look at the data, and when we present, tease out what truly is keeping our patients intubated longer. So my question is, how fast should patients be extubated? And the real answer, in my opinion, is whenever they're ready. And maybe in the operating room, and maybe as early as a couple of hours after arrival to the ICU. But if you adapt certain strategies, you will definitely shorten that time. I think the big strategy that we all should adapt is ERAS. Once you see it work, you become a buyer. I worked in a hospital that just opened up a cardiac surgery program who had a lot of resources, so they were able to adapt ERAS in its whole entirety. Not only that, they created a universal bed concept where every patient stays in the same room. The room kind of transforms around them. They don't leave the ICU, so you have the same care team providing them their care throughout their whole entire stay. The length of stay was short. Patients were being discharged within 3 to 4 days after their surgery. So if you're able to kind of adopt all these processes, you will have early discharge, good outcomes, and early extubation times. In terms of adopting a process, you have to commit as a team. It takes a whole team: anesthesia, surgery, your ICU team, your respiratory team. So everybody has to get a buy-in to this process. I think adopting an OR extubation strategy, irrespective of whether you extubate patients in the OR or not, will help you shorten the intubation time, because a lot of the things that are done in the OR in terms of sedation, pain management, will translate into early extubation times later. Cost can be reduced other places. We need to talk $800 or $900 here in terms of the care that we deliver in an American healthcare system. I'm not sure that has a lot of translation, but if we put the cost up front and providing good preoperative optimization for our patients, we'll probably see more benefit. The time that we all are sticking for is 6 hours, because now that's a quality STS metric. But earlier is always better, but we should definitely try to extubate our patients within 12 hours to decrease the complications that we're seeing with prolonged ventilator times. And that's all I have.
Thank you very much. Our next speaker is going to talk about the dreaded complication of a surgical site infection after cardiac surgery. And she's going to present, for the first time really, the ERAS Cardiac Society turnkey order set to reduce SSIs. So thank you.
Hello, my name is Cheryl, and I'm a coordinator nurse for a cardiac surgery program in Springfield, Massachusetts. But I'm also a member of the ERAS Cardiac Society, the executive board, and the work I'll be presenting today to create this SSI turnkey order set is something that our ERAS Society has been working on with key experts in the field. The QR code for our turnkey order set is going to be provided a couple times throughout this presentation. So if you didn't get it on this slide, there'll be a couple more opportunities. So what do we know about cardiac surgery site infections? We all in this audience know how devastating they are. It is a dreaded complication. We know they're costly, they're financially costly, and they're also very costly to our patients from the quality of their life. We know, I don't have to explain what it goes on for our patients when they have a SSI. They're frequently associated with staph species and often preventable. So that was really what drove us to want to put together this turnkey order set. And we looked at specific guidelines related to SSI and prevention and consensus statements. The main ones we used are on the screen. I'm not going to read them all to you, but we also had other validated guidelines to use as well. So let's start with pre-op, and what did we find? We found that patients that are screened, if you do a nasal swab and they screen positive for MSSA, they are at a 3 to 6-fold risk for developing an SSI. And as a little background, about 15 to 30% of the population is a carrier for MSSA. About 5% are carriers for MRSA, which puts those folks at a 9-fold increased risk for a surgical site infection. So whenever possible, screening for this is ideal. And you might say, well, maybe we could just treat everybody. Well, what has happened over time, there's become mupirocin resistance with that approach. And it also, if you just treat everybody, you're not going to tease out certain patients. Those that screen positive for MRSA, we would recommend, from what we've discovered, that those patients should receive a dose of vancomycin in addition to their routine antibiotics. We also found that there is emerging evidence to support a one-time dose of povoiodine nasally that is being used and studied in some of the orthopedic literature, and may be an alternative option if you don't have the mupirocin screening in your institution. So also important pre-op is to really assess and define your high-risk patients and to modify their risk whenever possible. So things that we think from what we've been studying that are really important is finding and eradicating any existing remote surgical site infections. Some patients might not think it's important to tell you about that thing that's going on the foot. It's important to ask them about that. It's also important to assess for a history of MRSA. Leverage your EMR, looking for histories of infections, checking A1C on everybody. This is going to tease out some patients that you don't know are diabetic. It'll also show you who you should take a pause and help get their diabetes in better control. This is a huge part of risk reduction in the post-op side, and the better control you have before is going to help you on the post-op side. Showering, bathing, instructing patients about that, as well as assessing for nutritional deficits and optimizing them, only clipping, and of course, smoking cessation whenever possible. This is the time where you're starting to partner with your patient. You're letting them know they're a part of this, and just like we all know how devastating these infections are, helping the patient know why we want to prevent this. So interop, things we've learned, making sure your antibiotics are the recipe that is the best for your patient. So there's kind of 3 buckets. The first bucket is majority of patients are going to receive cefazolin, making sure it's weight-based and that the redosing is meticulous. If you're unsure about your redosing, there's recommendations for opting for a cefazolin infusion. Patients' absolute contraindication to a cephalosporin should have vancomycin and gram-negative coverage. And then there's this other group that are going to be those patients with the cefazolin and the vancomycin that I alluded to. Who are those people? Those people are the patients that test positive for an MRSA with a screening, or you're at high suspicion that they may have MRSA colonization. There's also a subset of patients that you might want to consider giving a dose of vancomycin in addition to their cephalosporin. Those are your patients that have been in the hospital for 3 days. They've been admitted from the outside facility. These are the patients maybe living in a skilled nursing facility, patients that have been exposed to other antibiotics. You just finished eradicating some other kind of infection right before their surgery, or patients having a prosthetic valve or a vascular graft insertion surgery. Intra-op, key things, making sure your skin prep is alcohol containing. We're recommending CHG, of course, the glucose control, normal thermia when coming off bypass, vancopaste to sternal edges, and minimizing OR traffic. You may be thinking, we do all those things. Make sure you're doing all those things, which is why a lot of SSI prevention guidelines recommend the use of a checklist to ensure you really are doing what you think you're doing. We wanted a quick way that we could have a mnemonic for those patients that are at high risk. These are the people you really want to focus on. You're in the OR. And thanks to Dr. Chattery, we came up with a perfect mnemonic, which was COBRAs, because like snakes, we hate SSIs. And so we really like this. And it helps you to think about these COBRAs when you're pre-oping patients, to think about what is modifiable here. But then when you get to the OR, continue to think about this. Is this somebody that could benefit from the rigid sternal fixation? Is this somebody that we could maybe use a negative pressure dressing for? And again, all along, letting patients know that they're at risk. So post-op, again, maintaining normal thermia, good glucose control, your antibiotics no longer than 24 hours. And as you get close to beyond that 24 hours, that first 24 hours, it really becomes engaging with the patients. They are going to go home. They need to know how to take care of themselves from a hygiene perspective, an assessment perspective, when to call, who to call. Anything is starting to brew, you want to be on top of it. So I can't emphasize that enough about how much the patient needs to be involved with this. We also recognize that patients should be encouraged to prevent dehiscence with sternal splinting for coughing and sneezing. So key takeaways from our TKO that we would like to impart today are the importance of that pre-op assessment and optimization. So your nasal screening, your whatever things that you can do with that patient to help prevent this are going to go a long way. And then once the patient is under our care, making sure we're customizing it. Weight-based, can't say it enough. You're using vancomycin, make sure it's weight-based. Make sure that you're redosing your antibiotics, your timing is meticulous, and focus on those high-risk patients at all. And this will help with preventing that devastating SSI and preserve patients' quality of life, which is so valuable and what we're all here for. And I thank everybody for your time.
Thank you so much for introducing the SSI prevention TKO. Now allow me to introduce our next speaker, Dr. Daniel Engelman, who is a medical director on the Heart, Vascular, and Critical Care Unit at Bay Medical Center, and the founder and also the president of the ERAS International Society. And in this session, we will talk stage 3 AKI should be a never event.
Thank you. So today we're going to talk about AKI. This is near and dear to my heart, area I'm very much interested in. These are my disclosures, none of which are relevant to this discussion. So just a brief overview of AKI staging. We're all probably familiar with this, but there's stage 1, 2, 3. How do you remember it? It's very simple. KDIGO staging. We're not going to use the urine-based, the urine output-based. We're only going to use, because we're STS members and following their rules, it's stage 1 is a creatinine bump of 0.3, stage 2 is a double, 2 double, easy to remember, 3 triple, easy to remember. You get your last baseline baseline creatinine before surgery. If it triples, that's stage 3. Or if you need new dialysis. That's what's reported to the STS, stage 3. They don't look at stage 1 or 2 when you report to the STS. How prevalent is it? You can see here, the more complicated your surgery, the higher the incidence, but all types of AKI from all kinds of surgery occurs in 43% of patients in this one large study. And you can see mild, moderate, and severe going across and the relative commonality of it. How big a deal is it? Well, if you have no AKI after CABG, you have a 9 or 10% readmission rate in the first 30 days, which is a metric, but it goes straight up the more AKI you have, stage 1, stage 2, stage 3. So AKI at any stage increases readmissions. Here's a central message. Any stage of AKI causes permanent damage to your kidneys. It's not just the stage 3. It's not just that creatinine that remains elevated. You come in the hospital, you have cardiac surgery, the creatinine bumps even only a little tiny bit, 0.3, goes back to normal. The cardiac surgeon says, great, I didn't hurt this patient, he's fine. Not true. You've irreversibly harmed that patient. How do we know that? From all kinds of studies in the past. Here's one with this little red dot on the side shows the 0.3 increase of a creatinine during the first 48 hours after cardiac surgery is associated with a 10% increase in mortality within 30 days. And we can see over 90 days, reduced short-term survival with stage 1, stage 2, and stage 3 AKI. Long-term, up to 10 years, same story. You have a, quote, reversible bump in your creatinine during your initial hospitalization from cardiac surgery. You've irreversibly shortened your life. Why is that? We think that you're losing your functional renal reserve and that the patients are more likely over the long time, over their entire life, to go into CKD. So how do I know anything about AKI, and why am I qualified to stand up here and teach you about AKI? I think this is why, because over the last 7 years, this is my STS data from Bay State Medical Center where I work and run the intensive care unit. And you can see on the bottom screen, we have about a 1 or 1.2% incidence of stage 3 AKI when you're expecting 2%, which if the most important part is the top of that screen. My O to E is always in the 0.5 range. I have half the expected stage 3 AKI over the last 6 or 7 years. So something I'm doing is working, or our team is doing. So how do we do it? That's what I'm going to discuss. It all started with these ERAS guidelines, which we published back in 2019, in which we suggested goal-directed therapy should be performed to reduce postoperative complications. What is GDT? It's implementation of a KDIGO bundle of care. We talk about that a lot, but what really is that? What does that mean? Stop the nephrotoxic agents in those patients that may be going into AKI, ACE inhibitors, nonsteroidals, ARBs for the first 48 hours after surgery. Closely monitor serum creatinine and urine output. Avoid hyperglycemia in the first 72 hours. Insulin drips. Consider alternatives to radiocontrast agents if the patient needs to go get some agents after surgery. And close hemodynamic monitoring using a pre-subscribed algorithm. So what is that? Well, in general, it's trying to get the patient optimized, euvolemic. Some patients are hypovolemic, some are hypervolemic. You have to use whatever technology you have to figure that out. And the critical time is in that first 24 hours after cardiac surgery. That's what you need to do. In the guidelines, we also came up with a 2A recommendation. It wasn't very strong, but it's there for biomarkers that are beneficial in identifying patients at risk for AKI. And that's the magic at my institution. And this is what we published in 2020, was using urinary biomarkers to reduce AKI following cardiac surgery. And the biomarkers we use is a commercially available agent of TIMP2 and IGF-BP7 combined. It's called NephroCheck commercially. And what it is a cellular stress marker before injury. It's bumped a good 24 to 48 hours before the creatinine goes up. The creatinines are never elevated the day after cardiac surgery. I tell my team I don't even want to hear them. Do not tell me the morning after cardiac surgery what the creatinine is, because it's always unchanged. It's a delayed biomarker. It will not go up the morning after cardiac surgery. The patient may be oliguric, which is a sign of impending AKI, but this biomarker really works early. It's an alarm protein. And it all came out of this one study from 2019, which showed in the green that in patients who were followed, who subsequently went on to stage 2 or 3 AKI, their biomarker was significantly elevated in the first 6 hours to first day after cardiac surgery. So that's this magic window where you can see an elevated biomarker, but a normal creatinine. And that's what I use in my algorithm. I look in that little tiny window. Because we can see this is the biomarker levels on the left. And when that biomarker increases to the 0.3 to 0.7 range, which is the first arrow and the second arrow, we can see the risk for AKI, stage 2 or 3, dramatically increases. This is where it starts to get into the 30-40% chance that you're going to have AKI in the next 2 days. So that's the kind of the pivot point in the 0.3 to 0.7 range. So we developed this acute kidney response team. Every morning we send this at 5:30 in the morning, this urine. We send a tiny little aliquot of urine. It comes back in half an hour. It's in our medical record. And we act on that. The multidisciplinary team then acts immediately based on what that level of that particular biomarker is. And you can see on the right here, negative, less than 0.3. It's normal. Fast track this patient. Take the lines out. Stop all the craziness. No blood transfusions. Send them to the floor. You can give them your ACEs, their ARBs. Nothing to worry about. These patients will not go into AKI. In the 0.3 to 0.7 range, keep a close eye on them for the first 12 hours. Watch them till the afternoon of that first post-op day. Make sure they don't become oliguric. If they do, put them into the right high group. These are 25% of our patients who have a biomarker over 0.7. These ones get aggressive goal-directed fluid therapy. We optimize them, optimize their cardiac output, their index, their filling pressures, make sure they're euvolemic. Some patients are fluid overloaded. Give them aggressive diuretics. Watch their urine hour by hour. Have a threshold that may actually be a little lower to transfuse these patients and work with your nephrologist. And this is how we have reacted. We found that after cardiac surgery, 75% are less than 0.7, and we focus now on this other 25% of high-risk patients. What happened? We essentially eliminated stage 2 and 3 AKI. We brought it from 2.2% down to almost nothing, 0.3 or so. We had an 85% decrease while instituting this protocol. So you'd say, well, let's only test our high-risk patients. Let's look for patients who are at high risk pre-op for AKI, because this test costs about $100 per test. So each patient gets one test. It's $100. It's money. We didn't want to spend it. It turns out you can't predict who's going to have an elevated biomarker after cardiac surgery. The normal risk factors that we're all aware of, age, diabetes, pump run time, balloon pump, everything, it didn't relate to it. So why do some patients have kidney stress after cardiac surgery? It's multifactorial. I can't answer it in one sentence, but you cannot say, well, I'm just going to check the high-risk patients. You have to check everyone, and you will be surprised which patients are positive. And what happened after we did this, not only did we drop stage 2 and 3 AKI, we actually went in Q3 of 2020 when we really got this thing going to 0, which was unheard of. We also decreased our readmissions, which was probably somewhat related to that, which was great after isolated CABG. So now we get to the topic that we sort of discussed, which should new persistent stage 3 AKI, I don't mean necessarily dialysis, but new dialysis is important, or tripling of your creatinine, should that be reportable? Should that be a never event? Well, the government, Medicare in the United States, has these HACs, these hospital-acquired conditions, and here's a whole list of them, that you have to report, and they affect Medicare fee-for-service claims. They affect how much money the hospital can collect on a particular hospitalization. And they are already looking at AKI. New AKI, if it requires dialysis, which is a subset of the stage 3s, they are dinging the hospitals. So it's coming, it's real, and I'm proposing that if you get a patient with new dialysis after cardiac surgery or a tripling of their creatinine, you should take a little time to sit back and have a multidisciplinary audit of that patient. Could we have done something different? Identified something earlier, gotten the hemodynamics improved earlier, kept them in the intensive care unit longer? Was there something that could have been done to prevent it? And I would challenge you that there probably was. Here is a published AKI turnkey order set that we put out in January of this year in the Annals. You can use the QR code, but basically it describes everything I just talked about, but actually tells you the bedside order. Here's how you do it. If your bedside practitioner can say, well, I like that order, let's do it, let's optimize our patients. You don't have to use the biomarker to use this turnkey order set. That's just one little tiny component of it. And I'm happy to answer any questions. Thank you for your attention. Yeah, let's open up the floor to questions regarding these first 4 lectures, and then we'll do the last 2 afterwards. For anyone in the audience who has any questions, please come up to a microphone. I've gotten a couple for our speakers unless somebody else has one, while we wait to kick them off here. My first question is for Dr. Chatterjee. Is anyone actually seeing a post-op AFib patient and sitting on rounds and measuring their CHADS-VAS score? we talk about it, but to figure out who's going to get anticoagulation. Are we really doing that?
So are we doing it? Probably not as often as we should. So within our rounding, we are deliberate about calculating the CHA2DS2-VASc score as we contemplate how to go about anticoagulation. So I think one of the take-home messages is cardiologists they see AFib and it's an automatic anticoagulation. And I think as you dive deeper into the literature, what you gain from that is that I think post-op AFib is a unique phenotype because it's different. And so we calculate a CHA2DS2-VASc score. We also take into account things like AFib burden. Is this like sustained AFib? Is this one or, a couple of isolated episodes? But, so that's the short answer.
Dr. Barron.
Good morning. I'm Lauren Barrett. I'm in Houston, Texas Heart. I was wondering, hang on, short people problems. I was wondering if you all could talk about, for each of these risks, one of the major risk factors is cardiogenic shock and preoperative creatinine, particularly with stroke and with AKIs. What do you think about optimizing the patient's hemodynamic status with either dobutamine, balloon pumps, Impellas? How do we think about that when we have a patient who's high risk, maybe they're walking in ambulatory shock? How do we, as a group, what are your thoughts on preemptive care for these patients and trying to increase their forward flow? I don't know yet if it's worth it, but your experience would be helpful, what you think.
Yeah, I think it's a great question. I'll take a stab at it. That's sort of what the IMPACT trial is going to look at, is optimizing patients who are high risk. And they have specific criteria of what is high risk, and they're going to randomize those patients to have MCS, mechanical circulatory support, through an Impella 5.5, through an axillary cut down. And I do think we're going to probably show less complications. All these complications we see, extubation, we'll extubate them earlier. They'll have less AKI. They'll have less strokes. That's my prediction. I don't know. But the Enhanced Recovery After Surgery Society is a strong supporter of what you're prescribing, that we shouldn't just jump in and take care of these patients once they show up in post-cardiotomy shock in the intensive care unit. All of this needs to be backed up and looked at. Can we predict which patients are highest risk and do something about it before surgery? Maybe Dr. Aurora can jump in and answer some thoughts about that.
Yeah, so I don't know if I have a formal thought process around this per se, but when those patients are metabolically deranged, taking the OR is always associated with worse outcomes. So ischemic VSD or others, we've been putting people on ECMO preoperatively, even for 12 to 24 hours to resuscitate them before taking the OR, or longer if they stabilize well, and we can push them out longer, depending on the patient. So I think there's an opportunity to resuscitate the body and the patient before you take them to the operating room. Question, Dr. Aurora? I'll go to Alan first.
Dr. Hamden?
The patient that marks out in the third class.
Lift up your mic a sec.
In the patient who sort of marks out in that third class of the nephro check, so high risk, transfusion obviously is not a benign thing, so any issue related to transfusions just done for that purpose?
Yeah, there is an issue. Every transfusion is a problem, just like you're pointing out. So transfusions help for cardiac O2 delivery to the stressed organs, including the kidney, and yet every transfused unit of blood increases your risk of AKI. So it's a catch-22. There's this balance, and I go through it every single day on rounds. Yes, no, and I'm tugged in different directions. So, and I don't really know of my algorithm which of those components was most protective against AKI. So you're asking a great question, and it's definitely a balance.
I would add to that, Dan. I would say that transfusions are bad, anemia is bad. So I think one of the roles is trying to get to patients who are anemic preoperatively and try to optimize them, IV iron or whatever other strategies that might be, so that if they can come to the OR less anemic, they're less likely to get transfused.
Thanks.
Hey, Kurt Wozniak, San Francisco. I really liked your talk. And over the years, I've worked in a variety of different ICUs that have pretty radical different strategies when it comes to diuretics and the use of Lasix. Could you just give us a sneak preview as to how you use Lasix in your unit, when you start diuresing, what your sort of algorithm is for that?
Yeah, it's goal directed, so it's all based on whatever non-invasive or invasive monitor I have. We pick a goal. We pick a CVP. We pick a pulmonary capillary wedge pressure if we have in a SWAN, or we like to use non-invasive and do fluid challenges. And I'll tell them, keep giving fluid until the patient's not fluid responsive. You give a bolus of 250 of saline, you look for a 10% increase in your stroke volume. And I'm sure Dr. Grant might also have some thoughts about LASIK stress test. Dr. Grant, how do you use LASIK as a stress test a little bit?
So I was actually just going to say, I don't believe in biomarkers. I think they're expensive. I don't trust the data.
I'm sorry, we don't want you at the mic anymore. You may now sit down. No.
What is interesting is two things. One, you said to me at one point, and the other one, which I think is a recent publication in Annals. So the first is, if you on post-op day 1 have a creatinine that's lower than you went into the operating room, that may be protective. So you might actually have not sustained an injury and may be able to just kind of fast-track that patient out of your ICU. So that's one thought. The second one was this idea of a LASIK stress test. So you could give them a dose of LASIK, see if they respond. If they don't respond, double that dose, see if they respond, et cetera, et cetera. And I happen to be a believer that if you're not a responder to LASIK, it's not because the LASIK has hurt your kidneys. It's more a sign that your kidneys are not ready to open up.
An early sign of AKI.
Exactly.
I agree with you. Yeah. Dr. Aurora.
Yeah, so I have several questions, but I guess I'll yield to a couple. Let me start first with you, Dan. So when you, outside of the biomarker controversy, which I'm still not sure about either, but I'm trying to learn.
You may also sit down.
Well, we're going to try it. We're going to try it at our center and see if I like it or not. But more about when you actually have someone now with AKI and you have your kidney attack team descend on the patient, what does your swoop look like? What do you actually discuss and what are you trying to figure out as a root cause? And what have you found to be the most common root cause?
Cause.
Correct.
Actually, we don't look at the cause.
Okay.
We don't know. We just look at the treatment. We say, how can we optimize this patient early? Creatinine's still normal. They're still making urine.
Right.
But this biomarker is screaming stress kidney. How do we unstress the kidney? That's what I tell the patients.
Right.
Everything's great. Your kidney's stressed. And then I ask them things like, have you ever been in the hospital before? Yes. Did you ever have a problem with your kidney? Oh, yeah. 20 years ago, I had diverticulitis, and they told me I had a kidney problem. And you look back in the record, they had a creatinine of 2 back then. So they have poor renal functional reserve. That's why some patients have it. We don't know.
Yeah, so it may be something we should consider developing as a swoop checklist like we do for VAP and other sort of HAIs, that we have a patient who's got a pneumatic injury. Do we actually then think about the things that could have caused it as a root cause of what we would do differently in their care pathways? That's something for us to take away from this. 2, then, for Dr. Yemen, thank you for your talk. We did a survey a few years ago looking at what the typical demographic of most intensive care units have in terms of their staffing. A large percentage of our units are open units managed just by the surgeon. The second most common phenotype was anesthesiologist, followed by pulmonary critical care. So I think you speak to a large number of our colleagues that take care of our patients. And your thoughtfulness around knowing your team is important, but teams need to evolve.
Yeah.
So how do we then take people of your phenotype or who are maybe expert intubators like anesthesiologists or others to move them past that initial fear phase that you described,
Yeah.
to be innovative and help progress care in your units?
So I've actually done CTICU for the last 10 years, so I'm probably in our team the most experienced in the ICU. But a lot of my team members are first, second year graduates. A bulk of them are ED, so they're expert intubators. But I think it's, at least in big cities, it's changing because ICU care is being bundled. Now you have critical care teams, right, that rotate from one ICU to another. So you have to kind of adapt to that strategy. 2, we embrace early extubation, but we also have to bring our nursing staff along with us. I think the challenge for us in our ICU is we actually have a very young and rotating nursing team. So just to get them on board has been quite a bit of a challenge. I think once you get 1 or 2 of your elderly nurses or your most experienced nurses on board, the fast track extubation is actually taken off pretty rapidly. I kind of cheated on Dr. Pluskis and went away for a year and helped start a new program and came back to Morningside. And during that year, I actually worked with an experienced group of surgeons who really embraced ERAS and extubated 50% of their patients in the operating room. And this was a brand new program. And you can see the transition very quickly. At the beginning, everybody was quite hesitant, but once you got used to the process was easily accepted. So it really takes an effort from everybody, but I think the one emphasis that we should all make is it's not the extubation in the OR that's the key. It's the pre-op optimization of patients and truly embracing ERAS. And you have to optimize your patients and make them stronger so they can succeed. You can't just yank out the tube on somebody who's not ready to be extubated, right? Just because that's a goal you're trying to accomplish. You really have to set them up so they can succeed. And that process really needs to be embraced. And that takes effort from the clinic staff, from the OR staff, and obviously the ICU staff. So it's not one group of people. You have to get everybody on board. And that's what I've learned.
Thank you. Let's continue now. Dr. Salinger, would you give the next talk, which is Re-op for Bleeding, the Surgical Closure Checklist.
Good morning. This has been a great meeting, really relevant and informative talks, and I'd like to thank the program committee for inviting me to talk. Usually if you've been invited to talk, it indicates you have a strong knowledge base in the subject, above average experience in the particular facet of surgery you've been asked to speak about. So I'm honored to have been invited. I'm trying not to read into too much the fact that the particular topic where my name popped into my colleagues' heads was on patients who have surgical bleeding postoperatively. But this may be the most useful talk of the entire meeting because I can cut your surgical bleeding in half. Those are my disclosures. And just to remind everyone, the larger rubric that surgical bleeding falls under is patient blood management. And there's three main pillars of patient blood management. Preoperatively managing the patient's anemia, intraoperatively minimizing blood loss, and postoperatively tolerating anemia. The one that I'm going to focus on is minimizing blood loss intraoperatively. And as you all know, there's multiple facets to this. And specifically what I'm going to talk about is minimizing surgical bleeding. So as far as active bleeding, you can obviously, we all know, have coagulopathic bleeding or surgical bleeding, but I'm going to focus on surgical bleeding. I wasn't sure where to start, so I started thinking about what is surgical bleeding. It turns out we kind of know what surgical bleeding is, but we can't really all define it the same way. There's been several pretty good attempts at defining it. One of the most recent is the Universal Definition of Perioperative Bleeding, which was published by Dyke in 2014 and is specifically aimed at cardiac surgery bleeding. And they defined excessive bleeding as greater than 1 liter of chest tube output within 12 hours, which I think most people would agree with. The BARC classification says greater than 2 liters within 24 hours. And then Colson and his group published a very reasonable definition for bleeding, except it involves higher level math called multiplication, so I don't use it. I thought about how I define surgical bleeding in practice, and this is basically what I follow, although I had to think about it to come up with these numbers, so I don't really follow this formally. And this is basically a modification of what you would find in Kirkland's textbook, maybe a little more restrictive. So 400 cc's in an hour, we're going back to the OR, or these other parameters, and the patient's not coagulopathic. And of course, you can't talk about postoperative bleeding without remembering that tamponade is really taking a patient back for bleeding. We all know the signs, and early post-op, one of the most common signs is your bleeding suddenly stops, and you're happy for about a minute before you realize the patient's about to code. So when we go back to the OR, what do we find? This is I thought, an interesting meta-analysis, and I was a little bit surprised by some of the findings. This is from Bianchari and published in 2018. First of all, of the patients, they combined 18 studies to do this meta-analysis. So they had 51,000 patients, and about 2,500 of the patients were re-explored. And of the patients that were re-explored, 65% of the time it was surgical bleeding, which is already different than anything you'll hear on rounds. And of that 65%, 40% was cardiac, 25% was chest wall, which I was surprised by that as well. And the cardiac causes that they found were something related to the conduit, which I accept because I don't harvest the conduit, so it's not my fault. Anastomotic, 10%, some other suture lines, 16%, and then chest wall, either the sternum or the mammary bed. I can tell you on rounds, in our hospital, 100% of the time, it's the sternum, or nothing. In 2013, Gabriel Lohr, who was a resident at the time at the Cleveland Clinic, and the group there published this really, I think, seminal article about a bleeding checklist. And they looked at almost 6,000 patients, and they had a formal checklist for bleeding, and they cut their reoperation for bleeding rate from 3.1% to 1.9%. And this has been repeated by several authors since then. And they've all shown a significant reduction, almost in half. And some of them did cut their re-exploration rate in half, including this recent one in 2021 from Ali at the Papworth Hospital in the UK. So what is the checklist? What do people do to decrease their bleeding re-op rate? So this is what they did at the Royal Papworth Hospital. They're all kind of similar. They looked at 5 kind of categories of places: the operative sites, like your anastomoses and your cannulation sites, and where you cut the heart or the aorta. Then after they looked at operative sites and their cannulation sites, then they looked at their mediastinal sites and their chest wall and their sternum. Chest wall is basically mammary bed. I thought the Cleveland Clinic it was a little bit kind of simpler, but a very similar checklist. They looked again at their surgical sites, cannulation sites, proximals, distals, aortotomies, atriotomies, then their kind of mediastinal sites, the thymus and the pericardium, chest wall and sternum. So I think we all kind of, or most of us probably do this before we close, but the question is, you do it as a formal checklist every time the same way. And this is actually what I started doing a couple of years ago. I call this the Maryland checklist. That's a little bit of an aspirational title because not everyone at University of Maryland does it. I do it every case, and a couple of my junior partners do it. And this is I think this is the way I do it, and it's simple. First of all, the distals I don't look at after I come off bypass. I look at the distals when I take the clamp off, and then I don't look at them again. But this covers the distal bleeding will be found with this checklist. So I look, I never realized, like, I was looking at the thymus and the pericardium. I just call it the neck. I just look up in the neck. I start up there, and then I just start coming down. I look at my cannulation sites. I look at my proximals. I look at any otomy that I made. So any, like, vent or retrograde, or if I cut open the left atrium, I look down. If I made an aortotomy, I look down and I just see if that's bleeding. And then there's 2 spaces I look at that basically tell me if a distal's bleeding or something behind the heart. And they were both taught to me at separate times by mentors of mine. So I look at the diaphragmatic well, and I actually call it the Landsman area, because Steve Landsman from Sinai taught me that when I was a resident. He said, if there's no bleeding back there, you can close. And then I look at that area down, like in the kind of the transverse sinus, but where the left atrial appendage is. And I call that the pit of despair. And one of my former partners in private practice, Dr. Ed Lundy, taught me to look there. And he said any bleeding from like your Lima to LAD or your OM or your your left atrial appendage, if you manage that, that'll usually end up down there. And that's served me well to make sure my OM or my LAD is not bleeding or my appendage. Then I look at the mammary itself to see if there's blood collected. And then I put my wires in, I look at my wire holes in my mammary bed before I pull the wires together. And so that's a very simple way to do it. I look back at my last 800 isolated cabs, and my re-exploration rate was 1.4%. That's not, I don't have a comparison, but I thought that was decent. So I think the most important points is that the majority of bleeding is surgical bleeding when we're going to re-explore our patients. And that if we use a formal checklist, we can definitely, every publication has shown that you can have a significant decrease in your re-explorations. This wasn't part of my talk, but I just felt like I had to say it. Better to re-explore the patients early than to let them sit there bleeding and getting blood products. And as a specialty, we actually should come up with a specific formal definition of excessive bleeding, which will facilitate studying bleeding and using it as a quality indicator. Thank you.
Thank you so much, Dr. John Schellinger, for bringing us so much information on the surgical checklist. And allow me to introduce the next speaker, Dr. Natalia Girardi from Department of Anesthesiology, New York Presbyterian Hospital, Weill Cornell Medicine. And today she will talk transfusion, blood conservation 101.
Thank you so much. Good morning. As you heard, I am an anesthesiologist and intensivist at Weill Cornell, and it's a pleasure to be able to speak to you today. So thank you for the program committee for this invitation. I have no disclosures. So as we've already heard, and I'm sure you're well aware, there's been a lot of attention on blood transfusion since the seminal TRIC trial in 1999 first raised questions about non-infectious dangers of blood transfusions. And in recent years, there have been extensive recommendations from both the American and European societies on the appropriate use of transfusion in the perioperative period, including several specific, as you can see on the right side of the screen, specific guidelines for cardiac surgery patients. Data has been mounting, and we are more and more concerned about transfusions, but as you've already heard, the battle ultimately is between transfusion and anemia, and we have to pick a side, either being in favor or fearing transfusion or accepting anemia. The next 10 minutes, I'm going to discuss how to address this dilemma. As the previous speaker mentioned, the 3 pillars of patient blood management are again here for just as a reminder. So blood cell, first, optimization of red cell mass preoperatively, minimization of bleeding and cell salvage intraoperatively, and finally, restrictive transfusion triggers. So we'll start with blood loss and salvage. You've already heard a confession from the surgeons that it's generally a surgical problem, so I was really happy to that you started put that right out there. There are many guidelines that the most recent joint practice guidelines from 2021 highlighting strategies for blood management. As you can see here, though, the first few are actually directed at intraoperative goals, and there's actually only 2 Class 1 level of evidence A recommendations, and the routine use of red cell salvage using centrifugation and the restrictive transfusion threshold. We'll come back to that later. Now, when we do see microvascular bleeding, we have post-bypass bleeding. Traditionally, we relied on some empiric traditions and routines, and we were sort of a one, give them a round shop where 1 platelet and 2 plasma was sort of a first round of attempting to stop the bleeding. Some people ascribe to the 1-to-1-to-1 approach, but ultimately, it's sort of a hope and prayer and throw the book at them and hope it stops bleeding. The modern management is really directed towards point-of-care viscoelastic testing. And there's a variety of different choices out there when it comes to viscoelastic testing. We're a ROTEM shop, so I'm a little biased in that direction. But point-of-care testing, viscoelastic testing, gives us a lot more information than traditional coagulation tests. The viscoelastic tests actually can show us more than just the initiation of clot, but also the strength of clot and any fibrinolysis that may be occurring. The PT-PTT that we're most accustomed to looking at in the inpatient setting is only going to tell us this first, see my pointer now, it's only telling us this very first period of the clot formation, and that's the thrombin generation. Once an adequate amount of thrombin is generated and the clot starts to form, the PT-PT test is finished. That's the time it takes to get to that point. But you don't really see what happens to the clot afterwards. And the viscoelastic tests allow us to look at not only the thrombin generation, but then the period of fibrin polymerization and the benefit of the both clotting factors as well as platelets and fibrinogen. The thrombin generation completes generally between 10 and 15 minutes. You can see the A10 indicated here, which would give you an early indication of what the clot strength looks like, and we'll look at algorithms next that can use that. So it gives us really quick information from the point of starting the test to receiving that first strength of the clot is going to be about 10 or 15 minutes. The Society of Cardiovascular Anesthesiologists Clinical Practice Improvement Advisory gives some specific guidelines about how to interpret these tests and determine the order and the type of blood product that's recommended. You can see our Cornell algorithm on the left here, and we've implemented this now for about a decade. And the benefit is that we not only are able to get this early indication of specifically what is the deficit that the patient is experiencing, but we also have recognized that the early repletion of fibrinogen is probably most beneficial and frequently depleted. And you can see that reflected in both the SCA guidelines as well as our guidelines. Now, there's many studies that have looked at the implementation and benefits of viscoelastic testing. I selected this kind of recent guideline because it uses Quantra, which is yet another platform. And I want to show you there's many different choices out there. If you have TEG or Rotem or Quantra, they're all, I think, have their pros and cons. But what you see here is something we definitely recognized as well. This is 64 patients pre and post Quantra implementation, and about half in each group were isolated CABG. Most striking is what I've got the arrow pointing at here, which is that after implementation, the blue line being pre and the red column being post, you can see the amount of plasma went down dramatically. And that's been our experience as well. We may have traditionally thought we'll correct that PTT of 1.8 with some plasma. It doesn't really work. And if you can see it in a different objective way, it really points to what the actual deficit is. I'm going to reiterate again that sometimes when there's bleeding and the point of care viscoelastic test is normal, it might still be a surgical problem you just haven't found yet, but there are also some blind spots in this type of testing. There are some cofactors and minor factors that might be significant. So one is calcium, which is a cofactor in many of the reactions of the coagulation cascade. We know that, or there's some animal studies and in vitro evidence that acidosis is probably also problematic for the necessary coagulation reactions, and then finally temperature. These tests are performed, and this is true of the Klaus PT-PGT test as well. They're performed at 37 degrees, so the patient's hypothermia is not reflected in the testing, and therefore would not be able to identify hypothermia as a cause for bleeding. So the next thing we're going to get into is the transfusion trigger, and there's again been much discussed about this. The Titer 2 trial, which randomized patients undergoing cardiac surgery that had a post-op hemoglobin less than 9, were randomized to either a restrictive or liberal strategy, restrictive being 7.5 grams per deciliter and liberal 9. And they found there was no statistical difference in the composite outcome of infection and ischemia, and there was, in fact, a 1.6 absolute difference in the secondary outcome of mortality favoring the liberal strategy. So that was a little bit different than what we'd see in the TRIC trial. However, one of the major faults of this study was that it only randomized patients after surgery, and about 25% had already received transfusions intraoperatively. TRIC 3 looked at, again, a restrictive versus liberal, 7.5 versus 9.5, and 9.5 postoperatively, or an 8.5 once they got to the floor. And that was criticized a little bit because that's a pretty high liberal strategy, not very common to see that high of a strategy being employed. But this study really demonstrated non-inferiority of a restrictive guideline, and the subsequent meta-analysis of 13 randomized controlled trials further reinforced the non-inferiority of a restricted. So I think it's changing our paradigm, and we've certainly seen the transfusion trigger over time decrease. Now this STS data set looks at the actual use of blood. This is a 2018-19 sample. And you can look here on the left at CABBAGE, and you'll see that the median transfusion is still 1 unit of blood. Well, that's kind of curious, because when you are consenting patients for blood transfusion, you probably tell them you're only going to give them blood if it's absolutely necessary. And can you really say that if they only get 1 unit? We thought this was an interesting question, and we started to look into it. We looked at a population of patients having either CABBAGE or isolated aortic valve surgery, and we looked at patients that either had 0 red cell transfusions across their admission or 1 unit. This, over the 2010 to 2019 period, was over 2 million patients having either of those surgeries. And you can see 60% of patients received no red cells at all. 10% of the total population received only 1 unit for the entire admission, and about 30% received more than 1. Now, when you look at the patients, though, that got any red cells at all, that 40% of patients, you can see that 25% only received 1 unit. So when they received that first unit of transfusion, they probably didn't realize it at the time, but 1 in 4 times, that would be the only unit they received for the whole admission. And that really kind of gives you pause when you think about your transfusion triggers. Wonder if it actually matters? Well, it probably does. We found it's a huge sample size, so that of course helps your p-values, but we did detect a difference, and that was true in the all-comers as well as the separate CABBAGE and an aortic valve and propensity matched. We looked for what are the risk factors, who should we be especially concerned about when we're giving that first transfusion, and it looks like it's older, non-Caucasian, smaller BSA, and female patients. So we think this can raise awareness and help us do a better job of controlling our transfusions. Now I'm out of time, and that's somewhat intentionally. I didn't get to red cell mass, but that's because we have another talk in the next session, in the perioperative session that will follow this, and we'll be hearing from one of my colleagues talking about preop anemia management. So my takeaways are that point of care testing probably does help us reduce transfusions, not just red cells, but all plasma-composed therapy. There are no platelets big enough to fix some holes, so we still need excellent surgery. There's always the pro and con between anemia and transfusion, but probably anemia is the safer choice. And again, an ounce of prevention is worth a pint of cure. So join us in the next session and hear more about pre-op anemia management. Thank you.
Our last and final lecture now is on readmissions, enhancing discharge preparedness by Dr. Lauren Barron. Thank you.
Good morning. I'm one of the CT surgeons at Baylor and Texas Heart. And my biggest disclosures for you guys are that I've been in practice for about 1.5 years now. And this is coming from a place of how did I make it work rather than a place of 20 years of experience. And so take that with a grain of salt. And I would welcome your feedback if you've done something different that's worked better. So when I was making this talk, I started out with, well, okay, so what's the scope of this problem? And basically this is a meta-analysis and systematic review that looks at 9 million patients. And I was going to say, so this is why they are readmitted. No, that's not exactly right. That's not precise. This was the diagnosis that they were readmitted with. Why were they readmitted? Well, it turns out, this is data from New York, actually, about 16,000 cabs, and these were the risks. And that if you look up at the top, there's this area deprivation index. And to put it in simple terms, that's just a very granular way to look at socioeconomic status. And when I looked at this, I thought, well, it's got to be like mortality, right? If they don't have money or resources, then they're going to get readmitted. But that's not true. That's the thing that didn't come out for readmissions. What came out in readmissions were these, and I think it has more to do with the fact that the people in these categories are within a system that was not built for them. Example, if you are a surgeon or you work with female cardiac surgery patients, I challenge you to go into your hospital and find one of them a bra after surgery. Because
most of the patients who need a cab that are female are either young or on the older end, right? They present later. They either have some genetic component or they present later. And what I found out when I was starting was that my older patients don't want to walk down the hallway in what amounts to a sheet with no bra on. They'd rather not walk. And I didn't even think about the system not being built to facilitate them participating in their own care. And probably one of the most striking is language. So that's my son, Bryce, my adopted son, Bryce. He is an economics major at Mizzou, and he's going to Japan for a year to study business. And he was very excited, and I was thrilled for him to do this. And he said, okay, I sent you all the forms, the money thing, I need the money thing. And I'm like, okay, I got it. I said, Bryce, I really want to help you meet your deadline, but everything's in Japanese. I don't speak Japanese. So the forms were all there in a folder for me, in a drive, pre-filled out, but I couldn't read them because I don't speak Japanese. And he had totally overlooked the fact that I don't speak Japanese. And he lived with me for 18 years. So what does the language barrier actually have to do with anything? So non-English speaking patients are up to 25% more likely to be readmitted within 30 days. That's with a translator. That's with adequate translation at key points during the admission. So what does that mean? So in this, it's 90,000. Not only is it in the hospital, but the problem follows these patients out of the hospital. You all get that call from the home health nurse that says, hey, I think we need to readmit this patient. They're not able to care for their wound, or they're having a problem, or for whatever reason, their home situation isn't conducive to their healing, and so you readmit them. And if you are a non-English speaking person, you are also more likely to be readmitted from home health care. So whatever this problem is, it's following them from the beginning to the end of their journey. And one of my students actually, I said, well, you know, why are we having more Hispanic readmissions? I said, we have like pamphlets and there's signage. And she said, well, we should probably look at that. So we did. And what it turns out is that if you take what a patient sees when they Google, or dog collar, whatever, cabbage, what we found were that the websites that they encounter, 75% of those are written above the average national reading level. They're written at an 11th grade level. Cleveland Clinic, I'm looking at you, 11th grade level. The US population is on an 8th grade reading level. Only 23% of what you find is available in Spanish, in Texas, right? Because the Google algorithm should be pulling up these things. And she did the searches from Houston, Texas. So I thought about that, and when I'm getting ready to discharge patients, I always use the adage, okay, we're gonna get ready to prepare you for launch. And I always say that in the thoughts that maybe if I can get them to think about it before I get them out, then they'll have a more successful launch. And then I thought about how incredibly stupid it would be to send an astronaut into space with no training and try and train him in space, or her in space on the space station. Because it turns out, this is what an astronaut typically gets. They get orientation to how the system works. They learn what their guidance and navigation devices do, how to use them and how to access them. Something called orbital dynamics, which is essentially the fact that objects move differently in space. Materials processing, what do you do with all these new things, these new gadgets? How do you store them? What do you do with them? And then a smattering of other things that basically give them a common language so that they can communicate with mission control. It's not so different from when you try to send a patient home after surgery, right? They have to walk different, they have to eat different, everything that their beds are different, their showers are different, and yet we don't talk about any of that. So we are essentially launching them into space before we've taught them anything. And I think it's just as silly to do it with my patients as it would be to do it with the astronauts. So here's a question for you. Anybody know what this physical finding is? It's a positive Apple Watch sign. That's what that is. And do you know what that tells me? That tells me that this patient knows how many steps they take in a day. They know when they're closing their ring. I don't have an Apple Watch, but this is the hand of one of my she's 67, he's 67-year-old patients, and they all have Apple Watches. In fact, when I see this, I usually ask their wife or their husband to bring it and put it on them. Why? Because if I can tell the patients you need to take 300 steps by day 3 and 3,000 steps before you leave, they know how many steps they're taking. And when I get there in the morning and they're hiding their wrist from me, it's brilliant. I said, "You didn't get out of bed, did you?" And they know they're going to get in trouble. So they'll call the nurse and say, "We have to get up. She is going to be back and I have to have done my steps." It turns out those 300 steps by post-op day 2 and those 3,000 steps before discharge, those actually help prevent 30-day readmissions. And so it was this stepwatch is a much more expensive device than the Apple Watch is, but it wasn't the device. It was telling the patients what their goal was. And when I thought about how am I going to do that for all of the other little things, how am I going to orient them, how am I going to prepare them? Well, so what I came up with was that I want to give the patients the same spiel that I give them when they're in the hospital, but I want to be able to give it to them ahead of time, and I want to be able to give them access with their family and whoever else needs to see it. So I started making content, and probably by the end of the month, I'll have enough to just give them their own YouTube channel and have my cards reprinted so that the back of my cards has a QR code. And I tell them, take it home and get your grandkids, and I want you guys to watch it. Because the thing is I'm going to challenge them to do an IS with their grandkids and see who wins. I'm going to challenge them to stand up with no hands. This is an example.
The first one is sternal precautions. Everyone that has a sternotomy, meaning the bone that covers your heart, your bones get put back together with wires, and those bones have to heal just like a broken arm would have to heal. And so after surgery, we can't put you in a cast. And so you have to do certain things to protect that wound. One of those things is not using your hands to push off of things. And we forget, because look, when you stand up, most of us put our hands down here or here and push off. That's not going to work so well after a sternotomy. So instead, I want you to sit down in a chair and cross your arms. And then I want you to figure out how much you have to lean over or what you have to do so that you can both stand up and sit down.
And all of the content looks like that. It's all exactly what I would say to my grandparents. Exactly what I would say to my young patients, that I just need them to do the thing. I don't have to look professional doing it. I just need them to get the message. And my student, Natalia, actually, she's taking all of the videos, and I'll play it for you.
En una cirugía de corazón abierto, se pica el esternón por el medio y luego utilizamos alambres para unirlo. Para proteger este hueso que se está curando, no podemos ponerle un yeso como cuando usted se fractura un brazo, por lo que hay que aprender a movernos de una manera un poco distinta. No podemos utilizar nuestros brazos para empujarnos, porque eso le pone fuerza al esternón que aún se está curando. Es bueno entonces que practique pararse con los brazos cruzados de esta manera, de modo que pueda proteger sus huesos mientras aún se está curando.
She's a fourth-year medical student in Puerto Rico and got me on Twitter about a year ago and said, "How do I get a mentor? Could you help me get a mentor?" And now she came and she followed me around on rounds and spoke culturally competent care to my patients, and it was incredible. And so now she's taking all of my videos, her and her medical student group, and they're translating them all to something that's culturally competent. So when we talk about nutrition, they're going to talk about nutrition from a Puerto Rican or a Latin perspective, rather than the only one I've got. And so I think if I can communicate with patients, if I can meet them where they actually live, then those social determinants of health, those things might fall away, and we might find that infection wasn't ever really as big of a problem for readmissions as we thought. We just didn't know how to tell patients to look after themselves at home. We sent them into space without teaching them anything.
Thank you very much. This will have to close our session because we're out of time here, so we'll be unable to take questions at this time. But I'd like to thank all the fellow speakers for excellent talk and all the participants for the questions. Thank you. Have a great day.